Swayam Prabha. Digital India. Educated India.
Welcome to this lecture on cardiac action potentials. We know that the function of the heart is to pump blood to the different parts of the body. This pumping action is driven by the electrical activity of the heart. In this lecture, I will be discussing in detail the electrical activity of the heart. It was believed earlier that the heart is under neuronal control, just like the skeletal muscle. In the 19th century, it was demonstrated that the heart can beat on its own even after removal from the body of animals like frogs. This is the picture of Swiss anatomist and physiologist Albert von Kolliker. He did an interesting experiment with a German anatomist Heinrich Müller. So what they did was they took heart from the body of a frog, and then this beating heart was placed on the nerve of a nerve skeletal muscle preparation. And what they observed was, with each beat of the heart, the muscle twitched. And this proved that the heart was generating electrical activity, which could then spread to the nerve and then stimulate the contraction of the muscle. Now we know that the heart is capable of generating its own electrical activity. This is known as the myogenic theory. This theory has replaced the neurogenic theory that was proposed earlier. This is a video of an isolated rat heart that is perfused by the Langendorf system. So here what we do is we take the heart from the body of a rat, and then we tie the aorta to this cannula. The cannula is tied in such a way that the tip of the cannula is above the semilunar valves. We know that between the semilunar valves and the wall of the aorta, there are sinuses called sinuses of Valsalva, and these are the openings for the coronary arteries. So the heart is retrogradely perfused with Ringer's solution through the aorta so that it can go into the coronary arteries. Now the Ringer's solution that we give is oxygenated and also maintained at 37 degrees Celsius, and it contains all the nutrients which are sufficient for the contraction of the heart, and the heart can continue to contract as long as you provide the solution. So this heart is completely denervated. Normally the heart is supplied by the autonomic nervous system, the sympathetic and parasympathetic nerves. Today we also routinely transplant hearts, and these hearts are obtained from brain dead patients, and they are harvested from these patients and then transplanted to patients who suffer from cardiac failure. So the hearts that we transplant then start generating their own rhythm and start functioning in the recipient. Again here they are denervated and they are beating on its own. So we know that our hearts start beating from about 5 to 6 weeks of intrauterine life, and then they continue beating till we die. So suppose we take a 70-year-old person, and we know that our hearts beat 70 beats per minute. So if you do the maths for 70 years, you will know that our hearts are beating for about 2.5 billion times. Isn't it amazing that the heart is capable of continuously beating so many times? So it is capable of generating an automatic rhythm as well as maintaining this automaticity in a rhythmic fashion for a long period. So the heart is capable of automaticity as well as rhythmicity. Now let me ask you a question. Where is this automaticity originating? I hope you said it is the SA node. So where is the location of the SA node? So SA node is located here in the right atrium, on the posterior wall of the right atrium, close to the opening of the superior vena cava. Now the impulses from the SA node can then pass to the AV node by internodal tracts, or they can also spread to the atrial muscle and finally reach the AV node. So there are three internodal tracts. One is the anterior internodal tract, the middle internodal tract of Vengi back, and the posterior internodal tract of Thoral. Now the anterior internodal tract can also have an extension into the left atrium, and that is called the Bachmann's bundle. So the AV node is located in the lower end of the interatrial septum, again in the right atrium, and from the AV node the impulses spread to the bundle of his, which is located at the top of the interventricular septum. From the bundle of his, the impulses then pass into the bundle branches, the right and the left bundle branches. From the bundle branches, the impulses reach the Purkinje fibers and finally supply the ventricles. In the case of the left bundle branch, it can have two divisions, an anterior fascicle and a posterior fascicle. So this is the dissected SA nodal region of a rat heart. This is the right atrial appendage, this is the left atrial appendage, this is the inferior vena cava, and this is the superior vena cava. So the SA nodal region is located in the posterior wall of the right atrium, close to the opening of the superior vena cava. This is the video of the same picture showing spontaneous contractions in the SA nodal region. Now this is the picture of an isolated rabbit SA nodal cell. This cell was isolated from the rabbit SA nodal region by enzymatic digestion with enzymes like collagenase, protease and elastase. The cell appears like a spindle-shaped cell, and it is less striated with less sarcoplasmic reticulum and a lesser diameter when compared to the cells isolated from the atria and ventricle. This is the same cell showing spontaneous contractions. This is the picture of an isolated mouse SA nodal cell. You can see that it is spindle shaped, and you can also see the spontaneous contractions. This is another mouse SA nodal cell which is spider shaped. This is another cell which is elongated. So these cells come in different shapes and they are classified as spindle, spider or elongated cells. This is a mouse atrial cell which is longer, larger in diameter and also striated. So the SA nodal cells are usually smaller in length, smaller in diameter, they are having poor SR and they are also having poor striations. This is another mouse SA nodal cell. You can see it is spontaneously beating, and this was subjected to patch clamp technique with a glass microelectrode. So the cell membrane was sucked into this electrode and then a sharp suction was applied to break open the cell membrane. Then a technique called current clamp was used to measure the action potentials generated by this cell. So this is the picture of a mouse SA nodal action potential. So it has a depolarization phase and a repolarization phase, just like the neuronal and skeletal muscle action potentials. So this is the picture of a neuronal action potential. This you must have seen earlier. So they have a stable resting membrane potential of about minus 70 millivolt, and during depolarization the membrane potential reaches about plus 30 millivolt. And these action potentials are very brief, lasting only about 2 to 4 milliseconds. Now compared to that, these cells don't have a stable resting membrane potential, and during depolarization they go up to plus 20 millivolt. So they don't have a stable resting membrane potential because these cells lack the leak potassium channels and the invert rectifier potassium channels, which help the other cells to generate a stable resting membrane potential. So instead of having a stable resting membrane potential, the membrane potential drifts slowly towards threshold, and this is something known as slow diastolic depolarization, or the prepotential or the pacemaker potential. So somewhere around when the cell becomes minus 60 millivolt, the cell membrane slowly depolarizes spontaneously and reaches the threshold to fire an action potential, which will then undergo repolarization. Now we'll see the ionic basis for the SA nodal action potential. Now let's imagine this is an SA nodal cell, and this is the slow diastolic depolarization starting from about minus 60 millivolt, and then it reaches the threshold and fires an action potential which goes to about plus 20 millivolt. Now this will trigger the opening of voltage gated potassium channels, and there will be flux of potassium leading to repolarization. So these are the delayed rectifier potassium channels, and the potassium efflux will cause the membrane to reach a potential of about minus 60 millivolt, which is the maximum diastolic potential. On this hyperpolarization, another class of voltage gated channels will open, and these are called the HCN channels. Now these channels are opened on hyperpolarization, and these are non-specific cation channels which can conduct both sodium and potassium. But since the gradient for sodium is greater, sodium ions will move from outside to inside, causing a further depolarization. Now this will lead to the opening of T-type calcium channels and calcium entry from outside, and causing further depolarization. It is also now known that the SR of the SA nodal cell can spontaneously release calcium in a clock-like manner, and this is known as the calcium clock. So the SR of these SA nodal cells, they spontaneously release calcium very rhythmically and in a clock-like fashion. So the calcium that increases in the cell is removed by the sodium calcium exchanger, which removes one calcium ion and takes in 3 sodium ions. So there is a loss of 2 positive charges and a gain of 3 positive charges. So in effect, there is a net gain of 1 positive charge for each cycle of this exchanger, and therefore this will further cause a depolarization. Finally, when the membrane potential reaches the threshold for opening of L-type calcium channels, these channels will open and calcium will enter the cell, triggering the spike of the action potential, or the depolarization phase of the action potential. Now this will trigger the opening of voltage gated potassium channels, and then there is potassium efflux causing the cell to repolarize. So in the case of the SA node, there are 2 clocks involved. One is the calcium clock and the other is the membrane clock. So even the membrane proteins, the channels open and close in a cyclical manner or in a clock-like manner, and therefore this is known as the membrane clock. Now the SR calcium release is shown to be mandatory for pacemaking. If you block the SR calcium release, the pacemaker cell will not function. We have also noticed that blocking of the NCX can lead to stopping of the heartbeat. Similarly, blocking of the L-type calcium channels can also lead to stopping of heartbeat. In our experience, we have seen that blocking the T-type calcium channels didn't cause a significant change in the heart rate. Blocking of these HCN channels reduced the heart rate but didn't completely stop the heartbeat. There was a 30% reduction in heart rate. So this is the picture of the currents that are passed through the HCN channels. These are inward currents, and you can see that they are slowly activating and they don't inactivate. So these currents are called the funny currents, and they pass through these HCN channels, and the HCN stands for hyperpolarization activated cyclic nucleotide gated channels. So these channels can be gated by cyclic nucleotides like cyclic AMP, and they can increase the funny currents. So this channel protein is coded by a gene called HCN4, and the current is usually written as IF, where F stands for funny, or IH, where H stands for hyperpolarization. So why is it known as funny current? Because the discoverers of this current, they found that this behavior of this channel was very funny or peculiar. Most other channels will open on depolarization, but this channel opened on hyperpolarization, which was a funny behavior, and therefore they called it as the funny current. It is also known as the pacemaker current. So this is the IV curve for the funny currents. So you can see that the magnitude of the current increases as the hyperpolarization is increased to about minus 135 millivolt. And this is the point where the current reverses, or the reversal potential is about minus 10 millivolt. This is the activation curve for the funny currents, and you can see that these channels open at about minus 35 millivolt, and the maximum current is attained at around minus 135 millivolt. So these channels can be blocked by cesium, but therapeutically we use a drug called ivabradine, which can block these channels and this pacemaker current. So this is used in patients with chronic stable angina to reduce their chest pain. So what this drug does is it selectively decreases the heart rate, and when the heart rate is reduced, the myocardial oxygen consumption will also decrease, and therefore there will be relief of anginal pain. If you have a high heart rate, then your workload on the heart will be more, and it will be consuming more oxygen, and if the heart is ischemic, it may not be able to meet the demands of this heart, and therefore the patient will suffer from angina. So ivabradine is the only drug which selectively decreases the heart rate without affecting the contractility. Other heart rate reducing drugs like the beta blockers and calcium channel blockers, they reduce heart rate, but they also affect the contractility of the heart. Now the SA nodal action potential can spread to the atria, and the atria can develop atrial action potentials. So this is the picture of a rat atrial action potential, which was obtained in our laboratory by impaling the atrial tissue with sharp glass microelectrodes to record the membrane potential changes. So here we have the phase 4 of the action potential, which is the resting membrane potential, and normal resting membrane potential of the atrial myocyte is about minus 90 millivolt. Once it reaches threshold, it will fire an action potential, and this is the phase 0 or the depolarization phase, and this is followed by the early repolarization phase or the rapid repolarization phase or the phase 1, which causes an initial repolarization. Then this is followed by a plateau phase or the phase 2, which is then followed by phase 3 or the delayed repolarization phase, and the membrane finally comes back to the resting membrane potential or the phase 4. During the action potential, the membrane potential can go from minus 90 millivolt to a maximum of about plus 30 millivolt. Now let us discuss the ionic basis for the different phases of the cardiac muscle action potential. So here we have an isolated rat ventricular cardiomyocyte. If we put the electrodes of a voltmeter in the solution bathing the cell, we will not record any potential difference, and the voltmeter will record 0 millivolt. But if one of the electrodes is inserted into the cell, then we will record a potential of minus 90 millivolt, which is the resting membrane potential of this cell. So what causes this resting membrane potential? So imagine this is the ventricular myocyte. We know that the intracellular potassium is very high. It is about 150 millimoles per liter. The extracellular potassium concentration is low. It's about 5 millimoles per liter. And there's a large concentration gradient for potassium to move from inside to outside. And the cell is highly permeable to potassium at rest because of the presence of leak potassium channels and invert rectifier potassium channels. And therefore potassium will move from inside to outside along the concentration gradient. And as potassium moves out, the negatively charged phosphates and proteins, they are left behind and they start lining up on the inside of the cell membrane, creating a negative membrane potential. So this negative membrane potential will start attracting potassium from outside to inside. So there's a concentration gradient from inside to outside and then an electrical gradient from outside to inside. Finally, these forces will balance and there's no net movement of potassium ions. At this stage, the membrane potential will reach about minus 90 millivolt, which is the equilibrium potential for potassium. And we know that the resting membrane potential of these cells are close to the equilibrium potential for potassium. That means the RMP of the cell is determined by the potassium permeability of these cells, or the high potassium permeability of these cells is responsible for the resting membrane potential. Now let us discuss the ionic basis for the other phases of the cardiac muscle action potential. We saw that the phase 4 of the cardiac muscle action potential was the resting membrane potential, which is about minus 90 millivolt. So if this cell is stimulated by an action potential coming from the SA node, the membrane will start depolarizing, and once it reaches the threshold for opening of voltage gated sodium channels, these voltage gated sodium channels will open their activation gate or the M gate, and there will be rapid entry of sodium from outside to inside, leading to the depolarization phase. So now when the sodium enters the cell membrane will try to achieve the equilibrium potential for sodium, which is 60 millivolt. But in reality, it will only reach about plus 30 millivolt. Why is that? That is because as the sodium channels open, they also have an inactivation gate inside the cell, and this is called the H gate. So this H gate start closing and further sodium entry will not happen. At the same time, voltage gated transient outward potassium channels opened, causing potassium efflux, and therefore the membrane will start repolarizing, and this phase is called the early repolarization phase or the phase 1. Now this is followed by the opening of voltage gated L-type calcium channels causing calcium influx, and also the opening of delayed rectifier potassium channels causing potassium efflux. So there is simultaneous entry of calcium and efflux of potassium, and therefore the membrane potential remains stable, and this phase is called the plateau phase or the phase 2. Later this calcium channels will inactivate and the entry of calcium decreases, but there is continued efflux of potassium through the delayed rectifier potassium channels, causing the membrane to repolarize, and this phase is called the delayed repolarization phase or the phase 3. Now these delayed rectifier potassium channels, they are called delayed because they open and close very slowly, and these are rectifiers because they predominantly pass an outward current, and that is the basis for their outward rectification. Once the membrane repolarizes, it will reach again the resting membrane potential of minus 90 millivolt or the phase 4 of the cardiac muscle action potential. Now the impulses from the atria can spread to the AV node and produce an AV nodal action potential. So the impulses can travel through the atrial myocytes and finally reach the AV node, or they can also pass through internodal pathways from the SA node and reach the AB node to stimulate it. This is the morphology of the AB nodal action potential. It is similar to the SA nodal action potential with a slow diastolic depolarization phase, a depolarization phase, and a repolarization phase. Now if the SA node is diseased, it can spontaneously beat. So if the SA node is diseased and if impulses are not coming from the SA node, then the AB node will function as the pacemaker and it will generate its own rhythm at a rate of about 40 to 60 beats per minute. The action potential spreading from the AB node can reach the Purkinje fibers, and the Purkinje fiber can produce an action potential. So this is the picture of the Purkinje fiber action potential. It has a diastolic depolarization phase similar to that of the AV node and SA node. This is followed by the rapid depolarization phase caused by the entry of sodium ions. Then we have the early repolarization phase, the plateau phase, and the delayed repolarization phase. Another peculiar thing about this action potential is that the action potential duration is very long. Now the Purkinje fibers can also spontaneously produce action potentials if the SA node and AV node are diseased and dysfunctional. The Purkinje fibers can spontaneously beat at a rate of about 25 to 40 beats per minute and can cause contraction of the ventricle, and this rhythm is called the idioventricular rhythm. Now from the Purkinje fibers, the action potential reaches the ventricular myocytes, and the ventricular myocytes produce an action potential. So this is the picture of the ventricular myocyte action potential. You can see that the phase 4 is the resting membrane potential, that is minus 90 millivolt. Then there is a rapid depolarization phase, the early repolarization phase, the plateau phase, the delayed repolarization phase, and finally the resting membrane potential, or the phase 4. Now the duration of this action potential is much greater than the atrial action potential duration, and that is because of the difference in the delayed rectifier potassium channels that are present in these cells. So these cells have a slow delayed rectifier potassium channels when compared to the atrial cells. Atrial cells have a faster delayed rectifier potassium channels, and therefore they repolarizes faster, and therefore they have a shorter action potential duration, whereas these cells have a slow delayed rectifier potassium channel which opens and closes slowly, causing the prolongation of the repolarization phase. Now let us discuss the relationship between the ventricular action potential and the force of contraction. So here we have the ventricular myocyte action potential, and this is the tracing of the force of contraction generated by the myocyte. So the electrical activity of the myocyte will lead to the mechanical activity or the contraction. Now this contraction starts immediately after the depolarization and reaches a peak when the ventricular myocyte has completely repolarized. Now let us discuss the refractory period of the heart. This is the picture of the atrial action potential. So there are two types of refractory periods: absolute refractory period and relative refractory period. So from the beginning of the depolarization phase till the first half of the delayed repolarization phase is the absolute refractory period. So during this period, if the cell is again stimulated, the cell won't produce a second action potential. So this long absolute refractory period is because of the plateau phase. So during the plateau phase, the cell is still in a depolarized state, and because of this, the sodium channels will inactivate, and therefore they cannot open again to produce another action potential. For these sodium channels to open again, they have to close, and for this the cell membrane has to reach the resting membrane potential. From that state, they can be again reopened. Now the relative refractory period is from the second half of the delayed repolarization phase till the end of the repolarization phase. So during this period, if we provide a stronger stimuli, then the cell may be able to produce a second action potential. So during the relative refractory period, some of the sodium channels recover from inactivation, and therefore they can open and allow a second action potential to develop. The long refractory period of the heart prevents tetanic contractions of the heart. Tetanic contraction of the heart will cause the heart to go into a state of sustained contraction without relaxation. Relaxation is important for the pumping function of the heart because during relaxation phase the heart will fill with blood and this blood is then pumped out during the contraction period. Now let us discuss the spread of the electrical activity through the different parts of the heart. So here we have the SA node, and the SA node develops an action potential due to the opening of voltage gated L-type calcium channels, and this is the morphology of the action potential of the SA node. The calcium ions and other cations that enter the SA node can spread to the atria through the gap junctions, and once the atria reaches the threshold, voltage gated sodium channels will open, allowing the entry of sodium, and the atria will develop an atrial action potential. This will be seen as the P wave in the ECG. Now the impulses from the SA node can spread directly to the AV node through the internodal pathways. They can also spread from the SA node to the AV node through the atrial cells. So the sodium ions from the atrial cells can spread to the AV node again through the gap junctions, and then the AV nodal cell will generate an action potential due to the entry of calcium ions, and this will be the typical waveform of the AV nodal action potential. Now the cations that enter the AV node can spread to the Purkinje fibers through gap junctions. Now the conduction through the AV node will lead to the PR interval of the ECG. Now once the cations reach the Purkinje fibers, the voltage gated sodium channels open, sodium enters the Purkinje cells and produce a Purkinje fiber action potential. And these sodium ions can then enter the ventricular cells through the gap junctions and again trigger the opening of voltage gated sodium channels and sodium entry, resulting in the ventricular depolarization. Now this sodium ion can electrotonically spread to the neighboring regions of the cell membrane and cause further opening of sodium channels, and this will help in the conduction of the action potential through the surface of the cell membrane, and there will be continuous propagation of the action potential throughout the cell. So now you can see the ventricular action potential, and in the ECG you can see the ventricular depolarization as QRS complex. Now when the ventricle is completely depolarized, there is no potential difference, and therefore we will get the ST segment. Now this is followed by the opening of voltage gated potassium channels and potassium efflux, leading to the repolarization phase, and finally the T wave in the ECG. In the previous slide we have seen that the electrical activity can spread through gap junctions. So gap junctions are present between adjacent cells. So here we have one cell with a hemi channel made of 6 subunits, and in the neighboring cell also there's a hemi channel with 6 subunits. So these two hemi channels come closer together to form the gap junction. Now these hemi channels are known as connexons, and the individual subunits are called connexins. So the gap junction is made of connexin proteins, and these connexin proteins can be stained by immunohistochemistry. And this is the picture of a rat ventricle which was subjected to immunohistochemistry to detect the presence of connexin proteins. So these brown regions are the places where connexin molecules are present, and therefore these are the regions where the gap junctions are present. So these regions are actually the intercalated discs which are present between adjacent cells, where the cell membranes of adjacent cells come together. Now let us discuss the velocity of conduction through the different parts of the conduction system of the heart. The conduction velocity is highest in the Purkinje fibers. It is about 4 meters per second. The fast conduction through the Purkinje fibers causes the synchronous contraction of both ventricles. Atria and ventricle can conduct at a rate of 1 meter per second. SA node and AV node can conduct at a rate of 0.05 meter per second. The conduction through the AV node is slow, and this is responsible for the AV nodal delay. The AV nodal delay ensures that the ventricle contracts after the atrial contraction. AV nodal delay also prevents the spread of rapid atrial rhythms from reaching the ventricle. Now the conduction velocity depends on the diameter of the cell. The larger the diameter, the greater will be the conduction velocity. So Purkinje fibers have large diameters and therefore they can conduct at a higher rate. The conduction velocity is also dependent on the amplitude of the action potential. Greater the amplitude of the action potential, greater will be the conduction velocity. Now the slope of the action potential upstroke is also important. The steeper the slope of the action potential upstroke, the greater will be the conduction velocity. And therefore, in the case of Purkinje fibers, they have large amplitude action potentials and also they have a steeper slope of the action potential, which all will lead to a faster conduction through the Purkinje fibers. Now let us summarize what we have learned so far. So we have seen two different types of action potentials. This type of action potential is seen in the atria and ventricle, and this is called a fast response action potential. This type of action potential is seen in the SA node and AV node, and it is called a slow response action potential. Why is it so? Because in the atria and ventricle, the upstroke is very rapid, or the depolarization phase is very rapid, and that is because of the opening of voltage gated sodium channels. Whereas in the case of the SA node and AV node, the upstroke or the depolarization phase is less steep, and that is because of the opening of slow voltage gated calcium channels. Now the amplitude of the atrial and ventricular action potentials is larger, whereas the amplitude of the SA node and AV node is comparatively smaller. A definite plateau phase is seen for the atrial and ventricular action potentials, whereas no definite plateau is seen for the SA nodal and AV nodal action potentials. Atrial and ventricular action potentials have a stable resting membrane potential of -90 millivolt, whereas the SA node and AV node doesn't have any stable resting membrane potential. Instead, they have something known as the slow diastolic depolarization phase. Thank you for watching this lecture.